The authors have no financial interests to disclose in the subject matter of this film. In this video, the authors wish to highlight certain operative techniques relevant to those eyes with pre-existing encircling bands that require an aqueous shunt implantation. Scleral buckling surgery involves extensive conjunctival peritomy and slinging of rectus muscles. Silicone tires used for scleral buckling procedures are 7 to 9 mm wide. Fortunately, now circumferential silicone tires or sponges are extremely rare. Retinal surgeons prefer segmental scleral buckle in the quadrant of a retinal break and a 2.5 mm wide number 240 encircling silicone band to support the vitreous base. Location and height of the encircling band are crucial considerations in deciding where the episcleral plate of the aqueous shunt is inserted. It is essential to check conjunctival mobility and vital to avoid quadrants with scleral buckles. This eye has a segmental scleral buckle in the supratemporal quadrant and a 360-degree encircling band. Hence, aqueous shunt implantation is being done in the infranasal quadrant. Placement of the episcleral plate behind the encircling band is usually possible in anteriorly placed bands irrespective of whether the band is low-lying or has a high profile. The medial and inferior rectus muscles are sequentially isolated and space is created under each muscle. It is important to dissect thoroughly posteriorly to ensure that there is adequate space for the implant to sit comfortably. A large surface area low profile implant such as a 350 Barwell glaucoma implant, which is flexible and contoured to the shape of the globe, is useful to be placed behind or above an encircling band. Pars plana insertion of the tube is being done as the eye has had a complete vitrectomy with adequate trimming of the vitreous base. Insertion of the sharply beveled tube, length adjusted to place the tip in mid-vitreous, should follow the 23 gauge needle track. Placement of protective patches over a pars plana tube insertion site is also desirable, although erosion of the tube 4 to 5 mm or posteriorly is less likely. Posteriorly placed encircling bands could be low-lying or may have a high profile. With advances in modern vitreoretinal surgical techniques, glaucoma surgeons encounter these encircling bands much more frequently than the wider and more cumbersome silicone tires or sponges used earlier in scleral buckling procedures. Previous vitreoretinal surgical notes and a detailed evaluation of the peripheral retina preoperatively are vital to identify the location of scleral buckles and to avoid these quadrants during plate insertion. If the encircling band is posteriorly located and has a low profile, the episcleral plate could be sutured to the fibrous tissue capsule surrounding the band, thus reducing the risk of contact with the optic nerve. Rarely, aqueshunt implantation is likely to be impossible without band removal, as in this eye which has a posterior prominent encircling band. The retinal surgeon was consulted before surgery as removal of the band was anticipated. Blunt dissection is being performed to expose the encapsulated encircling band. The fibrous capsule around the encircling band was incised. This is the same fibrous capsule that forms around the episcleral plate of the glaucoma drainage device. It may have still been possible to implant the plate over the band with the wings positioned above the adjacent rectus muscles without band removal, but would have been extremely difficult to close the conjunctiva over the implant. The fibrous capsule is further relaxed, the encircling band is removed and the plate positioned in place. To conclude, aqueshunt implantation often offers the best chance of long-term success in refractory glaucoma following vitreoretinal surgery, but is challenging, requiring meticulous pre-operative planning, significant modifications in technique, on a very rare occasion would need removal of an encircling band provided underlying scleral thinning or ectasia are absent. Thank you.